Welcome to the Royal Australian and New Zealand College of Radiologists' 90th anniversary podcast series, where we celebrate 9 decades of excellence in radiology and radiation oncology. In this special series, we honour the remarkable careers, achievements and contributions of our members who have shaped our college and the profession. In this episode, we're honoured to feature Professor Mark Khangure AM, a trailblazer in interventional neuroradiology. With a career dedicated to advancing medical imaging and patient care, Professor Khangure has been instrumental in pioneering techniques that have revolutionised the treatment of neurological conditions. Professor Khangure's journey began with his training in the United Kingdom and Australia, leading to his significant contributions in Perth, Western Australia. In the mid-1990s, he performed some of the earliest endovascular coiling procedures, a groundbreaking technique for treating bleeding brain aneurysms without surgery. His work in this area has set new standards in neuroradiology and has greatly improved patient outcomes. In addition to his clinical achievements, Professor Khangure has made substantial contributions to RANZCR through various volunteering roles. He served as the college president from 2008 to 2009 and was the chief accreditation officer for radiology from 2010 to 2015. His dedication to the profession is further exemplified by his involvement in the college's WA Branch Executive Committee and his efforts in shaping policies and initiatives that promote excellence in radiology. Professor Khangure has also been committed to the federal and state AMA councils for over a decade, representing the fellows of the college and constantly lobbying for funding equipment, listing of new items on the MBS, and indexation of Medicare fees. Join us as we explore the remarkable career of Professor Mark Khangure, his pioneering work in interventional neuroradiology, and his invaluable contributions to RANZCR. We hope you enjoy listening to this episode.
Well, I started off wanting to be a physician. I trained in the UK, and in fact, I was a medical registrar in neurology, had my medical membership. And at that stage, there was a publication in the journal called Hospital Medicine, which indicates what the opportunities were for consultancy based on the number of registrar and the number of vacant positions. And for physicians, the odds ratio was 1 to 13. But radiology, psychiatry, anesthetic, rheumatology were 1 to 1. I was interested in neurology, and at that stage, there were a couple of procedural applications to neuroradiology. One was myelography, the other was angiography, and the third was pneumoencephalography, all of which fortunately have been superseded. So I got quite interested in radiology. I was good with my hands, and that was the start of radiology, which I started in 1974. I did 18 months in the UK, and at that stage I had enough of the NHS, had enough of the weather in the UK, and we decided to emigrate. A colleague of mine that I started radiology with had been a ship's doctor with P&O, and he'd been to Perth, and he was very impressed and just said at the end of the day, look, it's a small place, but it's got a phenomenal future. And he and I both applied at the same time. He got the registrar position at Sir Charles Gardner Hospital, and I got the radiology registrar position at Perth Hospital. So we came out supposedly for 2 years in 1976, and it's been a long 2 years, we're still here. So basically, that was the sort of getting into radiology. I enjoyed the registrar position at Perth Hospital, which was a very dynamic, evolving department. The head of department at that stage was Trevor Simon, who was one of the previous college presidents, and he was he's now retired, but his specialty interest was neuroradiology. So he and I actually, after completing my registrar training position, I did 18 months in the States, came back, and the training in the USA was interventional. At that stage, not so much neurointerventional, but general and neuroradiology. And basically, I came back back to Perth, and I was in the right place at the right time, because Trevor, Simon and myself started the interventional procedure, which probably is one of my, how should I say, lifetime's achievements, because we worked together and we recognized, the unit was recognized as a merit excellence in the particular procedures, and we had federal funding to treat patients from interstate, whose costs were covered by that grant. And in fact, we had patients coming from not just Australia, New Zealand, where their government paid, and also from various parts of Asia. We then very early on established a small part-time fellowship position, which when Dr. Simon retired, I became the director of the interventional unit, established a fellowship position, and that still operates to this day. So we've had neuroradiology, interventional and diagnostic fellowship positions in the unit, which is now moved to Charles Gardner Hospital through reorganization. And so we have people who've trained with us working in Sydney, Melbourne, New Zealand, in USA, 3 or 4 people in the UK, a couple of people in continental Europe. So the position still continues. It's been a very, very strong part of the specifics of the radiological journey. I was fortunate enough then to be appointed as head of department and director of the imaging unit, which we at Royal Perth Hospital have nuclear medicine as part and parcel of administration under imaging. So the hospital has a number of directors, and one of the directors was relating to imaging specifically, which includes nuclear medicine and radiology. So at one stage, it was 3 roles: Director of Imaging Services, Head of Department of Radiology, and Head of the Interventional Unit, with a very active college commitment at the same time. So I think that challenges, obviously family and moving. So we left the UK with a 10-month-old with no relatives or family in Australia, and so the first couple of years were a bit harsh, but we made a very conscious decision when we left that we would not go back for 2 years, because I think anything less than that, you have not given the other place a fair chance. So we did go back after 2 years. I think we lasted 7 weeks and came back, which was good. Then the next move was to the USA with a 6-year-old, and my wife was pregnant with a second child who was born in the States. When I went to the States, there was no position to come back to. It was basically, I wanted to go and pursue a particular career. And I always believed that if you have an interest, the opportunities arise when you least expect it, but you've got to have the interest, rather than saying, going to hang on the opportunity, and then you're not doing what you really want to do. So that was, Apart from that, I think I have been extremely fortunate from a professional aspect of being in the right place at the right time, given the right opportunity, and those were grabbed with both hands. Coming back to the presidency, I came in at the time when the Rudd government was just elected, and we had Nicola Roxon as the Minister of Health. And Mr. Swinburne and myself, we were at the RSNA when the government was elected. We sent a letter of congratulations and indicated that we would like to meet with the minister, because we were thinking about quality and standards, that we would like to move in that direction with them. This had been already discussed with the health department, with the previous government. And it took the best part of, 7-8 months to actually get an appointment. And unfortunately, one of the issues was that people in the health department, people you had a discussion with 1 week, when you went back several weeks later, it was a different person altogether. So that was tough going. But nevertheless, I think what we did do during that period were a number of achievements. One was the specialty training program, where government funds the training. So we actually got a very big share for radiology, radiation oncology training. During that same period, we had the second full accreditation by the AMC. Dr. Chikira, when he was president, had the first. In my term, it was the second accreditation, which at that stage they went through. They spent a week in New Zealand, a week in Australian training sites, and came back with a number of suggestions, questions, one of which was that we had a syllabus but not a curriculum, because our position was that at the end of the training, the registrars are competent in A, B, C, X, Y, Z. And their question was, well, how do you assess them and how do they gain that specific expertise? So that led to the development of the curriculum, which was a huge undertaking. And so at one stage, in addition to being, the college president, I was quite involved with the curriculum, particularly my specific areas, neuroradiology. So I actually did the first draft of the neuroradiology curriculum with Dr. Cowan from Christchurch, who did the head and neck part, which was subsequently revised because I just didn't have enough time to spend. But that was a situation. We then started with this move where the cardiologists wanted to take over coronary CTA. So getting a conjoint committee together and getting some degree of agreement was another, I think, fairly challenging task, but which was successful in the sense that the college took the first step of organizing a conjoint committee under the college auspices. So in essence, yes, we had the cardiologist and the nuclear med, but the whole process was initiated by radiology with the college secretariat. So that ended up basically as a college ownership, which I think was the right step in the right direction. The whole quality and standards program in getting funding from the Commonwealth government really started just before I came in, but the actual final details of getting the money and getting on with the program came during that period. Don and I, with Jane Grimm, worked very hard to actually get, along with others, to actually get that going. Just before I finished my presidency, the last meeting, which was looking at future directions. During the presidency, there had been discussion as to the change in the college structure from the then Faculty of Radiation Oncology and Council to Faculty of Radiation Oncology, Radiodiagnosis, and also then the board. My vision was that we had a faculty of the two disciplines, but then there would be a third in due course, which would be a Faculty of Nuclear Medicine and Molecular Imaging, because I believe that nuclear medicine has more imaging component than functional, because MR and other facets have actually totally really taken over some of the functions. So there was a natural place for sit in there. The other strong belief was that the policy developments would be by the faculties, because the faculty is the body that has the largest representation, has the largest knowledge base, and has individuals from all states and all interests. Policy developed by the faculty, it goes up to the board for the board to prosecute. If there is an issue that the board has, obviously the board manages the fiducial and financial facet, but if there's an issue with policy, really the board needs to come back to the college, particular faculty, for further debate and discussion. It's interesting, I've been a counsellor with the Federal AMA as a representative of the craft group, radiology, the college, in essence, radiology and radiation oncology, and we've just changed our constitution where it's been set down in the constitution. Policy is developed by council. Policy is not the prerogative of the board. And the role of the chief executive is very strictly defined as the person who runs the secretariat but does not make policy. And I think personally at this stage, the structure of the board in this situation has not worked too well to date, because the board has made some decisions which have not been discussed with the faculty and its policy. So I think that I know it's early days, but it's something that that needs to be grappled with. We also had under the Rudd government the inquiry under Dr. Bennett, which is Professor Bennett, which was the commission looking into what the future of medicine would be. And we had some very lengthy submissions which came in at a very short time. But you know, that was sort of quite an eye-opener, quite a challenge. Okay, career achievements. And I've mentioned already interventional neuroradiology. I've been a great advocate that the radiologist should be a specialist, should articulate the fact that he or she is a specialist doctor and not a technician who only provides the imaging. There's a great confusion in the community of radiographer versus radiologist, sonologist versus sonographer. And I think personally, also there's been a great lack of initiative on part of the radiology fraternities, not just in Australia, right around the world, in not shouting from the rooftops of what radiology has achieved. If we look at all of the major advancements in medicine or surgery, they actually hinge on an initial discovery or development in radiology. So we go back to Röntgen, X-ray. Subsequent bit was radiological. The next development was angiography. Long before coronary angiography intervention came in, the development was radiological. We then have ultrasound. We then have CT. We then have MR. We then have interventional, which has taken over a lot of the more invasive procedures. Yet most of the patients actually say, my doctor, treated me with this, is not the radiologist. And when I was doing interventional neuroradiology, made it absolutely quite clear that I had outpatients clinic. We actually saw all of the patients, saw all of the relatives, saw the follow-ups, had equal admitting rights with neurosurgery for patients who were admitted to the ward or to the intensive care unit. Because I think that we really have to be clinicians first and foremost. And obviously, there's a little bit of a conflict with corporatization, dollar volume versus value. But I think, for my sins, at the end of 2007, I had a fracas with the State Minister of Health. And after 30-something years in the public sector, I resigned on a matter of principle and ended up in a private practice because I still had to earn a living. And it's a corporate practice, but I work on my terms. Basically, I do what I think needs to be done. And in fact, very early on, my reports are always signed as an opinion, because I say at the end of the day, as a consultant, having looked at everything else, I express an opinion. Right or wrong, it's an opinion. And the practice had initially issues that, their template was set up to make a comment, that I actually said, well, anybody can make a comment. I prefer to express an opinion. That was, so apart from interventional neuro, the third MRI unit in Australia came to Perth. And by agreement between Royal Perth and Sir Charles Gardner Hospital, the unit was situated at Sir Charles Gardner Hospital. So I was appointed as the first director. The unit opened in 1997, and I ran that unit, developed all of the protocols, got the clinical side, got the process where we got very comprehensive clinical histories, and some of the protocols are still modeled on that bit. And I was there until 1993, but in the interim, I was still working as an interventional, so it got too much to do both. So I gave up the position of director of MRI, went back to Royal Perth Hospital full time to pursue the interventional neuroradiology. side of the equation. I've loved teaching and training, with the registrars, and was a senior college examiner for 7 years. I think that really, from the point of view, has been the sort of professional side of the equation, other than to maintain every step of the way the patient comes first, and we actually have to have the quality and standards. And if you can't do something, you're not trained to do it, it's appropriate to say no, rather than actually do something half-hearted and damage the patient. Particularly with intervention, I've always advocated that if you do something outrageous and it works, you take the credit. If it doesn't work, the patient takes the crap. Excuse my language, but that is really what the ins and outs. Developments in radiology, I think I've already mentioned. Digital, after angiography, the next big step was ultrasound and CT. Digital subtraction angiography, which changed the process of angiography and getting immediate images rather than cut film. The old process was that, you had a number of films, the cassettes disappeared to be developed and came back, so it took a long time, you waited a long time. Particularly for neurointervention, where you needed to see something immediately, digital subtraction was basically the structure that changed the whole field. And then eventually, after MRI, the next development was PACS. Rather than having films disappearing everywhere, you now have the situation where you can have a conversation with colleagues interstate, overseas, and they can look at the same data set. So you have this really speed and expertise in providing for your patients. I mean, nobody knows everything. So sometimes you have an inkling, but you really want other opinions, and this allows other opinions to be sought very rapidly. And I think that's also allowed radiology to subspecialize. You, even whether it's a hospital or private practice, solo practice are virtually non-existent. You have a group. So if you've got a group with several different skills, it's only the hands-on procedure that requires the radiologist on site. You can supervise, but if you're looking at the imaging study as an opinion, PACS allows it to be seen anywhere, and that is wonderful. That has made a huge change into specifics of patient management. Films don't get lost. I think the one thing that will be made even more appropriate and speedy will be when the government's personally controlled electronic health record is actually functional. I mean, there's a lot of money being spent, but like all bureaucratic situations, they didn't listen to the individuals who were going to be the users. So it's developed as a technology, but it's not very user-friendly. But eventually, it will have all of the imaging data. So really, it doesn't matter where the patient is. If they've got a unique identifier, the imaging can be seen by any person who's looking after them, so you don't have to repeat, you don't have to delay. Patients go from one private clinic to a hospital. Sometimes they need surgery, and if the images aren't there, there's a repetition. So it's extra cost in the healthcare system. And it's expensive on the network as well, and it's radiation. I mean, the patient, if they have an X-rays or CT, that's unnecessary radiation. So that really has to be one of the facets. Currently, we're working on, we have been working for a number of years to get some sort of agreement with neurosurgery and some of the neurologists who want to pursue interventional neuroradiological procedure or interventional neuroradiology to ensure that the standards of the individual are of the highest quality and the same. It really doesn't matter which direction that you come from. Neurosurgery gives them a bit more understanding of the neuropathology. Neurology gets a bit more of the clinical side, but they lack the imaging. The radiologists lack the other two facets. So what we're saying at the end of the day, that the curriculum, when you come from these disciplines, has to incorporate all of those bits. So what comes out of the sausage machine at the end? The ingredients are the same. They've been put in at different places, and I think we're almost there. Which is, it's been taking a lot of time to get the Neurosurgical Association that deals with vascular work to agree, and the Association of Neurologists with Interventional Neuroradiology. And unfortunately, even within the college, within radiology itself, there is some, how shall I say, both lack of understanding and a desire that I want this without necessarily having the standards. I personally don't have a problem as to who does what, but they actually have to have the standards, because if you don't, the patient suffers. As a personal example, when I stopped doing angiography when I left the public sector, the private sector wanted me to set up an interventional unit, and I said no. The reason was, A, you didn't have the entire team. Secondly, the number coming in would be too small. And thirdly, to maintain your skills, that at the end of the day is detrimental to the patient. So I think that basically these are areas where you need, highly structured, specialized units, good volume of work going through, but you start with a fundamental training. Fundamental training has to be. And I think that we're moving some way towards that. And I think my next thought process is whether training structure in the college needs to be changed as people start looking at more in the way of subspecialization. We produce at the end of the day a general radiologist, that's fine. If you have somebody who comes in, let's say they come in from neurology or neurosurgery and they want to do neuroradiology, is it appropriate that we say they do 2 years of barium studies and whatever? That's a discussion which has to be had. We also need generalists. So whether we have a two-tier structure where you've got two-tier training, it's a bit like general physician and specialist physician, or general practice versus specialist, or whether you actually have a structure where you say, all right, there's 3 years of general radiology, which looks at the fundamentals. We can all look at chest x-rays. We should be able to look at a fracture. We should be able to look at a pneumothorax, simple stuff. And then you take 3 body areas where you spend your 2 years, and that's what you're examined on. And that's your scope of practice. Out of those 3, you might do a fellowship in one. So you're really highly specialized in one. You're really good at 2. You don't do the rest. I think you need 3 at least in order to cover the on-call and coverage at the hospital and at private practice. We're already looking at a separate body interventional cover from neurointerventional cover from general radiology cover. So basically, there's already a process, because the person at the other end to whom you're reporting wants value add. He doesn't want a generalist. He's asking you, he or she is asking you for a specialist opinion. And I'm afraid I've yet to meet a radiologist who's a specialist in the entire field of medicine, surgery, obs and gynae, pediatrics and psychiatry. It just does not happen. Memories regarding involvement with the college. Well, I started off at the branch level in 1982 as a branch secretary. And I was very keen on teaching and training, so I became the branch education officer into what was then the college's education board. I think that was by 1984. When I served there for a number of years, I was then appointed as an examiner, and then eventually senior examiner for neuroradiology, which I served until I took college counsellor position. The exam has changed dramatically. I mean, at that stage we had two 35-minute, two vivas of about 40 minutes each. We now have 7. It was previously a situation, a handful of films without necessarily going through individual teams. I think the college secretariat was a fraction of what we have today. Quality and standards really wasn't an issue. And I think there was more emphasis at that stage in a sort of negotiations of fees, etc., than really the education. To me, college at the end of the day is really all about education, standards, quality, maintenance, modification, and I think that as the structure of medicine as a whole changes, we have to evolve. We have evolved, but I think we have to continue to evolve. And I think perhaps we need to be one step ahead rather than reactive. I think one can see where the whole process is going. Now, for example, at this point in time, if you are looking at major developments in oncology, particularly, the next step is looking at the genome, then looking at not just the imaging, but the scientific data that's in the image, which is measurable. We need to start looking at our trainees to actually start encompassing that component. Otherwise, I know that there'll be other individuals who will actually be more than willing to do it. This is what I meant that, the college training structure needs to have a look. The horizon is actually widening. The scientific knowledge, personalized medicine hinges on getting that data incorporated with the image. So what you produce for the particular patient is measured. You can then start looking at the responsive therapy by measurement. As the old saying goes, once you start measuring, you have science. Until you do that, you can't call radiology a science. There's a lot of science in it, but we have not applied it. And I think that we don't have the tools. MRCT gives you a volume. We actually have computer programs which can actually very accurately measure that volume. They can look at all of the metrics which are in that data set to predict certain facets, and you can start looking at response. Instead of saying, I think there's a slight increase in something, you should be able to say there's a 5%, 10%, 15%, whatever, a real change which is measured, which is really what the oncologists want. They are looking at with their therapies to response, and we are not always providing it. We provide the imaging, but sometimes we actually don't do it too well. So the college has gone through, significant change, not just from the exam and teaching, but the structure from, as I said, a council and a faculty to 2 faculties, a board, which unfortunately is not quite perfect yet. It's in evolution. I'm sure it will get there. And obviously the various committees to do with education, including CPD. That was a huge change from the college, that we were proactive in putting CPD in place. I think the next step might be recertification. And the question is, how do you do that? I mean, if you ask people to resit the exam, you fail because you're not a generalist anymore. I mean, I'm a fundamental believer that you start off with information, then you have knowledge, then you have wisdom. Your final practice is knowledge and wisdom. It's not all information. I think the information is hidden in there. It's been applied, it's been gained. This experience which you actually can't get on a short-term basis. So the college is changing, and it's going to change further. But I think, radiology has a huge future if we grasp it.
Thank you for joining us in this episode of the 90th Anniversary Podcast series by RANZCR. Stay tuned for more episodes featuring the remarkable stories of our members. You can find more information and updates about our 90th Anniversary celebrations on our website and social media channels. Until next time, thank you for listening and being a part of this milestone celebration.